Oh. Good afternoon from Dr. Aranya Thongpiu. I'm from Thailand. On behalf of the organizing committee of the APACT 2021, I would like to welcome all of you to meet with our magnificent speaker, the two of them. I'm very excited. We have now in the symposium number 5, it's not the symphony number 5 though. It will be about integrating tobacco control into the NCD's care. Altogether, we have 3 speakers. The first one will be Dr. Sandy Gupta, my nice doctor. Will be on tobacco and cardiovascular diseases, update, concern, and what is next. And myself will tell you a short story how we do the tobacco use control in diabetics in Thailand. And the third speakers will be Professor Gupta also, Prakat Gupta, will be the use of alternative tobacco products as a threat to NCD. Now let me introduce one by one. Let's get back to Dr. Sandy. Get back to Dr. Sandy. Or whoever.
Yeah. Should I start?
No, this is Dr. Prakat. Wait a minute. I apologize for the inconvenience. Okay. Dr. Sandy will be the first. Little girl. I have his, I typed down your CV on this. So everyone in the world know you. I know you, but others do not. You have it? No. It's okay. Anyhow. I have a very beautiful typing on your Sandy. Sandy, you're now in the... Don't put CV on. You bring up the CV. I'm sorry for the inconvenience. My Thai staff cannot speak. No, Dr. Sandy, this is Prakash. Oh, Sandy, you're coming here. At present, Dr. Sandy Gupta is a consultant cardiologist in people cost baths in HS hospitals in the London, UK. He was graduated from St. George's Hospital Medical School, and he had trained at St. Bartholomew, King's College, and St. George's. And he became the fellow of the Royal College of Physicians of the UK. That means he passed the internship and the fellowship, everything, and he was a specialist at a very young age. And he researched in the inflammation of the heart disease. He had a recognition award from the British Heart Foundation. His interest is in the clinical cardiology, echocardiogram, coronary artery heart disease, invasive coronary angiography, and the pacemaker. Now, we'll come to the second guest speaker. Oh, let's welcome Dr. Sandy Gupta first. Now, we're coming to Professor. Professor, come on. When I look in the Google for the Prakash Gupta, I find 100 names on it. So I have to get back to Dr. Prakash Chandra Gupta. He's now the director of Hillis Shankaria Institute for the Public Health in Mumbai. He was the Doctor of Science in Epidemiology in Johns Hopkins. And then he was a visiting scientist in Harvard and adjunct professor of epidemiology at Arnold School of Public Health in South Carolina. Some of his eminent experience. 1984 and 85, he got the Takemi Fellow, Harvard School of Public Health. 1993, Fellow of the International Agency of Research Cancer in Lyon, France. You go very far. 1999, you got the WHO World Tobacco Award in May 31st in 1999. 20 years before me. I got it this year. And 2003, you got the Luther Theory Award from American Cancer Society for outstanding contribution of tobacco-free And then in 2009, long time ago, you were the president of the 14th World Conference on Tobacco or Health in Mumbai in 2009. Okay, let's start with Sandy. Sandy, are you ready? Sir?
Yes, I'm ready.
Okay.
I'm ready.
Just relax. Say what you want to say.
Thank you very much, Arya. Very, very warm and very vibrant introduction, and it's a real pleasure to speak from London. It's a shame I'm not in Thailand today, but we will hopefully meet next year. But I would like to focus over the next 30 minutes or so from a cardiology point of view and tobacco. So can I go back to about 170 years ago? Does anyone remember 1848? The reason is, in 1848 was the first publication of the harm of tobacco in the medical press. This is the Lancet, and it told us that delirium resulting from the habit of tobacco smoking is an additional evil to the number of other mainly harmful things related to the noxious habit. So, you know, 170 years ago, we knew about the harm, and we are still having conferences regarding the harm. If we go to cardiology, which is, again, my selfish focus with tobacco, it's about 60 years ago that in the Framingham database and the big, powerful studies, they found that cigarette smoking was a key risk factor for coronary disease. But, you know, all risk factors in coronary disease deserve equal attention. Smoking is not more important than hypertension, which is more important than diabetes, which is more important than hyperlipidemia. Everything deserves equal attention. Does anyone know how many people die every year in the world? It's about 55 million. And on a daily basis, in cardiovascular disease here, about 48,000 deaths a day. And the reason I show this is that there's COVID at the bottom there. I just put this into terms of perspective. The reason I say this is that every year, 17 million people die across the globe from cardiovascular disease, and they are not in rich London, New York, and Tokyo. 80% are in the emerging or developing countries. Now, let's forget about the deaths. Are we interested in survivors? And the answer is yes, because every year, 20 million people survive a myocardial infarct or a stroke. Now, why are survivors important? The reason is that in cardiology, not a single cardiologist on the planet cures a patient from coronary disease. They all come back. When we do ward rounds in the emergency department or coronary care, we see the old faces. When we're in the cath lab, it's often patients who've had previous stenting or bypass surgery. And if you look at an incident event, let's say myocardial infarct, peripheral vascular disease, and stroke, you know your chance for a further MI and stroke is 5 to 10 times greater. So please, when you see a cardiac patient, do not tell them they are cured. They will all come back. But you can extend the time before they come back by lower is better and addressing secondary prevention. So there is a famous summary to coronary disease. It's 3 words. Lower is better. So if you look at LDL, blood pressure, blood sugar, your waist circumference, your salt intake, your heart rate, your lipid, lower is better. And this is just a slide of hypertension. And you can see in yellow here, people with blood pressures of around 120/80, they live longer and have less vascular and renal and stroke events than blood pressure 135/85. So our targets are going lower. This slide is over 20 years old. And back in 1998, we already had 40 trials of lipid lowering. And the message was simple: lower is better. Greater the reduction in LDL, better the outcome. And if you look at different populations, you can see here in blue that the Japanese cholesterol is much lower than, say, Northern Europeans. and they have less coronary disease as a broad link. And this is an interesting photograph of heart rate. Have you ever checked your sinus rate? And if you look at different animal species, the ones that have a lower heart rate, like camels and humans, live longer. Again, lower is better. So I want to go back to a very famous study by Salim Yusuf. It's called the Inter-Heart Study. Question: is a heart attack in London the same as in Mumbai and the same as in Bangkok? The answer is yes. 80% of the world's MIs are explained by 4 risk factors: diabetes, cholesterol, blood pressure, and smoking. Yes, there are other risk factors, but they are very powerful 4. And you know what the Inter-Heart study showed in 52 countries? That smoking accounted for nearly 40% of attributable risk to the first heart attack. Very powerful. So we have in our armamentarium a lot of facts about smoking and cardiovascular disease. We know it can increase the risk of death from CHD by 70%. Smokers are 5 times more likely to have a non-fatal MI compared to smokers, etc. So if we look at the top leading causes of death in the world, and I think this Congress will have lots of similar overlapping slides. If we look at the top 8 causes of death, 6 out of 8 are linked with cigarette smoking and tobacco. And you can see here again, cardiovascular disease being a big issue. And you know, we talk about being a global Congress. It's interesting how 50% of the world's smokers live in only 4 countries. So we have to be proportional in terms of addressing, whilst every nation is trying its best as well. So back to cardiology. Let's cheer up the data a bit, because there's no doubt over the last 20, 30 years, we've made great impact in the management of patients, especially with acute coronary disease. Primary PCI, antiplatelets, beta blockers, ACEs, statins. And you know, if you look at all of these interventions, if you in Bangkok, Mumbai or London have an MI today and you get no secondary prevention, your death rate is high. Over 2 years, maybe 8 to 10% a year. But if you have an MI in Bangkok, Mumbai and London today, and you get the best cocktail of intervention, everything goes down by 20 to 30% with these secondary preventative agents. So when you and me have an MI, we want to leave hospital with a residual risk of 2.3%, not 8%. And you know, if you're a smoker with MI and you stop smoking, you reduce by almost 40%. So stopping smoking after an acute coronary event is as powerful as your beta blocker and antiplatelet agent. And this is the meta-analysis that showed this data about secondary prevention and the power of smoking cessation. Now, you know, we enjoy going to congresses, we enjoy speaking, but we do a lot of voluntary work, whether it's in schools and temples and mosques and churches for the public. And I remember going on the radio once and talking about risk factors, and a patient came on the radio and said, "Dr. Gupta, I'm fed up of listening to you, because all you say is eat this, stop do this, do this, do." He said, "When your time is up, your time is up, leave us alone." And you know what I said to him? I said, "Mr. Khan, in the year 2020, in the year 2021, it's very difficult to die, very difficult to die. But what is easy, if you don't eat properly, walk more, stop smoking, take your tablets, you will need your leg amputated, you will need your 3rd stent, you will need an oxygen cylinder." So what we have to tell our patients is that we're not interested just to give you more years of life. We want to give you healthy years of life. So stopping smoking improves your breathing, reduces your acute readmission rate, etc., morbidity reduction. So let's go back to your coronary patients. And you can see here in red how lesions in your main epicardial vessels, they progress, atherosclerosis. But if you cut back or stop, you can allow less progression of coronary disease. If we look at our interventions, whether coronary stenting or bypass surgery, we know that people that carry on smoking after lovely, powerful, life-saving interventions, they come back quicker. Double the chance of another bypass, 40% greater death rate after a coronary stent, if you're still smoking. And there's another question. How many cigarettes a day are meant to be harmful? Well, the reality is that the more you smoke a day, the data shows, greater the risk of an event. But even 1 cigarette a day is not as good as 0 cigarettes a day. So when it comes to smoking and cardiovascular disease, the conclusion is not lower is better, 0 is better. The other thing that is quite tragic when it comes to our work as a cardiologist, when we go in the cath lab and see young MIs or coronary care, often men and women, there's a higher rate of cigarette smoking. So what about this thing about second-hand smoking? And I know in the last session there was a lot of debate about smokeless tobacco and e-cigarettes, vaping and second-hand. And when it comes to cigarette smoking, one of the most powerful lessons we've learned in recent years is the benefit of banning tobacco in public places, because so many patients and people were fed up of dying related to smoking, and they were never a smoker. So there's no doubt every year secondhand smoking causing excess deaths. And I think Prakash will highlight later all the other kinds of tobacco that are out there, and we've already learned that it's not just cigarettes, there's so many other different tobacco preparations, and they're all equally harmful. And this is a slide, this is a fact you will never forget. Everyone always will remember this slide. For every 1 cigarette you smoke, you will lose 11 minutes of your life. And every time I show this slide in a lecture or congress or conference, I always see people adding up, how long have I got left? So, question, how many cigarettes are needed to cause a MI? Well, I think this goes back to if you are genetically prone, that even 1 cigarette could start causing harm in terms of the cells, inflammation, procoagulation, endothelial cell damage, and it may be enough to cause an event. Question, how quickly when you start smoking does a cigarette cause harm? Within minutes. If you look at mainly laboratory data, you can see within minutes rapid formation of adverse aromatic hydrocarbon free radicals and cellular damage. It's a bit like a glass of champagne. When you take a glass of champagne, it goes straight to the head with the bubbles within seconds. Next question. Your patients may ask you, doctor, nurse, pharmacist, okay, cigarettes are harmful. How do they cause harm? And you show them this slide, that there are many ways in which tobacco can cause harm. We've already heard, and I'm sure we'll hear much more on the harm of nicotine, the addiction. But also, 1 cigarette, I believe, has got about, 100 plus chemicals, of which 60 are carcinogenic. But there's multi-processes from procoagulation, inflammation, causing dyslipidemia, etc. But, you know, we can forever scold our patients and tell them off. Why are you overweight? Why are you drinking? Why are you smoking? But if you tell them the benefit of lifestyle changes and show them evidence, maybe this is much more effective. So what are the cardiovascular benefits of stopping smoking? Well, even as a short term, patients' data will show heart rate improvement, blood pressure improvement, lipid improvement. Patients will say their skin is better, they can breathe more, and as they continue stopping or being ex-smokers, then you can show evidence of less cardiovascular events. But you know, cardiologists and physicians, we enjoy prescribing blood pressure tablets. But if you are a smoker and you're on blood pressure tablets, perhaps those medications are not as effective. We as physicians and cardiologists enjoy prescribing lipid-lowering agents globally. But if you're a smoker and you're on lipid-lowering agents, perhaps those drugs may not be as effective. And it's a bit like aspirin. You know, you can tell your patient at follow-up after an acute event, you know that aspirin a day is thinning your blood, but you know that cigarette a day is thickening your blood. That aspirin is not working. So you can put it in language like that. Now, again, practical ways of moving forward, because I think we get stuck in these congresses of just giving this alarming data. We've always got to keep moving forward. What do we do next? So it's important to remember that patients will need maybe 5 to 7 goes at trying to quit. And we've got to support them and capture that day when they are finally determined or it works. And remember what Mark Twain, the American author, said, stopping smoking is the easiest thing to do. I know because I've done it thousands of times. So let's go to practicalities of patients or public who want to quit. Well, most smokers, this is very interesting. Many of them are addicted, but most of them, 70% evidence shows, want to quit. But how many can do the quit process on their own? Very few. Under 5% of smokers manage to quit just by saying, right, today, 3rd of September, all out the window, all in the bin. It's very difficult. Most of them need counseling and pharmacotherapy. This is an interesting picture of the brain of a non-smoker. This is the brain of a smoker. I've no idea what this slide means, but I like the pictures. I do know. This just tells you heavy uptake in active, alive nicotine receptors in addicted smokers. And the moment you stop smoking, they have a craving, they have this less stimulation, and they want to reach out for more. They need this kick. And this is why I was fascinated to see the benefit of varenicline or Champix globally, because it's a very clever drug that has 2 bits. One is it's a partial agonist, so it lands on the receptor in the brain and gives a little release of dopamine, so the smokers don't feel so bad. But the most interesting thing is that it inhibits or it prevents nicotine receptor binding. And this eventually, over a course of therapy, patients will say, I don't feel like smoking anymore. So if you look at the evidence, varenicline given to a patient with behavioral counseling support over a 3-month period is the greatest chance of long-term smoking cessation. And if you look at other agents, bupropion, NRT, counseling, you can see here, this is in cardiovascular patients, greatest benefit of stopping smoking with varenicline course. Now, obviously, our cardiac patients, we have to be careful with different kinds of interventions and pharmacotherapy. But if you look at this very famous paper from 11 years ago by Nancy Rigotti, they looked at coronary patients, stable, and they gave half of them placebo and the other half varenicline. And what they found, this is the placebo group in terms of quit rate, and here is the group that got Champix, much higher rate of stopping smoking. And in terms of adverse, very similar. So very reassuring data for the cardiac patients. And if you look at the EVITA study, I don't have slides, but that's in acute coronary patients, very similar kind of results. There's one other study I need to mention. It's called the EAGLES study. It was published a few years ago in the Lancet. It's a multi-center randomized trial in 5 continents, 16 countries, 140 centers, and 8,000 patients. And basically, it was to look at neuropsychiatric side effects of interventions and quit rate. Half the population, 4,000, had a history of neuropsychiatric problems. The other half didn't. And they looked at the quit rates of different interventions and also safety. And what they found in this very important paper, that if you look at different agents, in blue is varenicline, in red here, pink is bupropion, green is NRT, here's placebo. that your quit rate in the non-psychiatric cohort was highest with varenicline at short-term and long-term. And in psychiatric patients, yet again, we know they're very difficult to get to quit. Much powerful results with varenicline than the other agents. And again, this is at longer-term follow-up. But the most important slide is this. Was there any harm in these agents in this group of patients? And the answer is no. If you look at side effects with all the interventions, in fact, Champix had less side effects than placebo. So we should not be nervous or hesitant for any of these kinds of patients who are smoking for these kinds of interventions. So last few slides. I heard earlier that Thailand, like many parts of the world, is doing very well in reducing the overall population burden of current smokers. Even in the UK, around the war years, maybe 80% smokers. Now, I believe we are down to around 15%. So we're very proud on how we've managed to address this. But one of the most powerful things any government has done in terms of reducing smoking in a population is to be aggressive in banning it from train stations, restaurants, hotels, public places, schools, and hopefully when driving kids in a car as well. So I think those kinds of interventions, proactively, legislation, very powerful. And even if you look here, this is in 2007, when they banned smoking and looked at the heart attack death rate reduction, within a year, I think it was 11% reduction in MI mortality. And no other intervention is as powerful as reduction in cigarette smoking in the population. The other thing which is controversial is by increasing taxation, do we reduce smoking rates? And the answer is yes, because it's a bit like petrol, that if you increase the price of petrol, a few people will give up cars and start cycling. There is now a concept of sugar tax. If we double the sugar tax, sweet foods, perhaps people will stop buying and obesity will go down. So it's always a bit about punishment versus incentive. Should we punish the population or should we incentivize them? I will give you, let's say, a pregnant mother who's smoking, I will give you a £10 Amazon voucher if you stop smoking. Is that better than saying I'm going to take away your benefits if you don't stop smoking? So this is the ongoing debate: punishment, a carrot and stick. If we look at cardiovascular disease, bypass surgery, rehabilitation, ACE inhibitors, you know what's the most cost-effective intervention? A smoking cessation program, because we know it will reduce not only short-term events, but also long-term. In the UK, our population is whatever, 65 million. One of our biggest burdens in terms of healthcare costs is being an inpatient. And did you know, in my hospital, Whips Cross in East London, one night in a bed is around £300 a day, which is about £100 more than the Taj, Oberoi or Ritz overnight. It's expensive to be in a hospital bed. And this is what has been the biggest cost. And what they say now, that if you look at NICE and looking at cost effectiveness, for every £1 we invest in smoking cessation program, including pharmacotherapy, you know the return is £2.37 saved. There is no interest rate or bank or investment that gives such return as investment in smoking cessation. So, 5 A's. We have to ask our patient, whatever field we are in healthcare, we've got to advise them. We've got to assess them. Are they ready? We've got to assist them, perhaps offer the therapies, and we've got to arrange. And this is, I think, we're cardiologists, because we're very good in acute interventions, in the cath lab. We're very good in the ward round, coronary care, in cardiac rehabilitation. I think we need to do a bit more with our colleagues. We don't have to be experts in smoking cessation, but we need to have a friend, a colleague, a link for patients to go to. because patients tend to listen to us. We have to ask them about their tobacco use, advise them about smoking and quits, and refer or assess, assist, and arrange. And I think one of the big problems is that there is this concept of fire and forget. We will prescribe some tablets, but do we follow up and see, is the cholesterol controlled? Is the blood pressure controlled? Have they lost weight? Have they stopped smoking? So we mustn't lose sight of the follow-up. And you know, there is this concept called TM, teachable moment. And if you look at a maternity ward, if you look at the outpatient, if you look at when they come for blood test, the greatest chance that a patient is receptive to interventions is when they're in acute admission. So every inpatient in your hospital, whatever ward, surgery, urology, maternity, acute, get sorted in a hospital, look at the smoking rates and get advice while they're under our wing in the hospital. They'll be more receptive. I'm not going to go into e-cigarettes, but I think the healthcare professions are divided. The world is divided into two. One group say e-cigarettes are better than smoking, but the other group say, well, there's more data coming out, there is harm, there is addiction, and we're creating a new disease because many teenagers have never smoked before and they're taking up a new habit. So whilst I believe that e-cigarettes is a possibility for heavily addicted smokers trying to stop, I'm very concerned about the big long-term effects and also the increased disease causing in teenagers taking up e-cigarettes. So remember, the world is divided into two. We spend a lot of our time as clinicians doing a measurement and giving a drug, but we need to spend equal time with primary prevention, health promotion, and even if cardiologists and physicians are busy, we need to have nurse specialists, pharmacists helping us, physicians assistants. In a world of 7 billion people, back to this concept of divided in half, 3.5 billion are obese and overweight, and 3.5 billion are hungry and starving. For example, today 10,000 people will die from diabetes and obesity, but today 20,000 will die from hunger and starvation. Well, what have I learned? Well, I think this is just a small cog in the big jigsaw of this Congress, and it's such a pleasure to come back here virtually in Bangkok, and 2 years ago in Bali. I was there just giving the same messages that cardiology, we need to do more because the link with tobacco and smoking is clear, but it's all about the next stages which we have to nurture. The good physician treats the disease, the great physician treats the patient. And this is not my mobile, but I want everyone to look and understand. You know your HSBC bank account number. You know your passport number. Every one of us needs a risk factor number. 130 systolic, 75 diastolic, 4 cholesterol, 6 your sugar, 60 your heart rate. And if you want to be international, no sugar, no salt, and 100% exercise. I think I should patent this, yeah? Your risk factor number. Finally, what is the biggest room in the world? Does anyone know? The biggest room in the world is room for improvement. Thank you very much, Ari.
I think it's about the same in Thailand. But I have to show you all of your slides to my cardiologist, and I'll be more than happy that they will follow you. Would you allow me to show this for them? Sir? Yeah, Sandy, yes.
I will send you a version. Yes.
Yeah, okay, thank you very much. I'm very glad. Professor Prakash, would you wait for 15 minutes before I run my slides? Okay, that will be my time for 15 minutes only, because we will have to close.
Please go ahead.
Yeah, thank you, Professor. Okay, my name is Dr. Araya Thongpiu. I am the endocrinologist from Paulo Memorial Hospital. So, bring my CV, a very short one. I am 20 years older than Sandy, but I can learn very much from you today. I appreciate it. Okay, my slides. You can bring up all of my slides. Okay, you look at my face. Oh, okay. That's my photo when I was very young. I am an endocrinologist since 1978 in Paulo, which is very small hospital, 260 beds only. But I was the president of the Thai Diabetes Educator Association for 4 years in 2001 and 2004. So I had my responsibility to bring all of the diabetic patients to come to the good key process indicator. So I joined the HA program, and I learned a lot from them. And we did, as I will tell you in my story. I joined the Thai Physician Alliance Tobacco 2007, and then Professor Somsi assigned me to do the tobacco cessation in NCD because I had shown the good numbers in my own hospital. So she gave me all of this work until now. So let me begin with the story. I'm going to tell the story. That's not much for the research. The first slide. Okay, whatever. I have to move. It's okay. Okay. Wait. Okay. The first slide begin. The second slide will be the map of Thailand. Before I do any Thai work, I have to do it on my own hospital first. After I did it on my own hospital, paper. Nothing has come. I'm sorry for this inconvenience. Meanwhile, you can save all of the question and answer. Okay. Then อะไรต่อ ตรงไหน Okay. That's my hospital. It was founded in 1972, and I joined the three alliance. That's Physician Alliance, and the second one is a Professional Alliance, which includes 22 professions. And the last one is the Thai National Alliance against for tobacco-free Thailand. We aim that we are going to have tobacco-free Thailand, and that's my small hospital. During my year of the president of the Thai Diabetes Educator, I joined the accreditation program to set up the towards clinical excellence network for diabetes and followed by hypertension because it's very similar.
Excuse me for interruption, Arya.
Yeah.
Can you ask them to make the screen bigger? It's very small right now. Can't really read.
Can you? Oh. You make it bigger. You cut down the one on the right. Look, come here and I'll show you what happened. You don't have to worry about my face. You show the slide. In that T-cell, we need the personnel. We need to train the personnel in multidisciplinary team. We need the process of tobacco cessation counseling for diabetes. That means 5A, as Dr. Sandy had said. And then we follow the outcome of the diabetes and the hypertension. That's okay. I joined the, okay. Then the first job that I get was to กดกลับเป็นไงกดกลับไปยังไงมานี่สิ Dr. Somsi assigned me toแล้วต่อสิ Okay, that's 2012 and 2014. We need 16 hospitals in 12 provinces. We have to select because we didn't know who can do it. So we have to choose the best of the 16 hospitals to join them. We prepared them, we follow up the results, we need the quality improvement, and then I have to go out and survey them in the place. This is a picture of what we had done. What we do is that I tell them what to do. Smoking cessation. Why? Because it causes a lot of complications to diabetes. You can prevent primarily because the smoking can cause diabetes itself. What and why? And then who? All of the team. Everyone, including the housekeeper, do have to know, to ask, and then advise our patients in Paulo Hospital to come to see the doctors in the NCD clinic. And how? We tell them how to do. What, why, who, when. Even the outpatient or inpatient clinic, you have to do it all the time. Everyone, everywhere, everybody, and I teach them how to do. And I bring all of the 16 hospitals from 12 provinces in Thailand. I'll show you the map of Thailand a little later. And then after that, that means I and my team, go out to survey them in person at the right place and ask them what to do, and we'll spend about 6 hours in one day to follow. And then we have the standard. These are the 8 standards and 43 criteria for the leadership, for later we'll have the leadership. We have 5 criteria. We have to communicate to the hospital staff and the patients. 5 criteria. We have the personnel competency, 5 criteria. We have to search for the smokers in the hospital, 4 criteria. We have to do the process, and we have the material for them, including the medications. And the most important is to diagnose by the doctor. This is the most important, and put down the ICD-10. So the medical record team can follow. So in my hospital, if my patients come in, they know how many patients in Dr. Araya care, how many of them do smoke. I know it right away. And the 6th one is to do the environment to prevent from the secondhand smoker. And then the community. We teach them to go out in the districts and to see in the school or in the any companies that join them. Number 8, we have the results, the 10 criteria for the leadership, for doing for the personnel, and doing for the patients, and then doing for the community. And all of these, they have to know how to approach, they have to know how to do, they have to get up the results, and they have to integrate with everything in the hospital and integrate with the government. Dr. Sandy, these are my patient care process. It's very small, but I will tell you what to do. These, when the diabetic patient comes in, they have to entry. How do they entry? They get the vital sign and everything else. And then everyone in the hospital do know how to ask and advise. If you see them smoke, you can tell them, please go to see the doctor so-and-so in the NCD clinic, or to Dr. Arya in the M clinic. Ask, and then you come to the assessment. You assess for the DM, you get the blood drawn, you do everything for your patient that day. And then you assess for the heaviness of the smoking. This can be done by the nurse who is well trained. And then you reassess whether they can stop smoking in the next visit. So you ask, advise, assess, and then you can assist. You have to evaluate if they need any medications, whether it's bupropion, varenicline, or whatever, and we can prescribe. And the pharmacist will help us on this. And after this, we'll to empower them, give them some idea of what to do when they go home. We do the STAR technique. You set the date, and then you tell people around you, and then you avoid the chance of smoking, and then you remove all of the utensils. And the last one, we arrange them to come back to our clinic. And these are the A1, A2, A3, A4, and A5. And we have the 1600 free telephone consults in our country. And I did it for three rounds, 2 years each. In each rounds, I get the CPG, the first one, the second one, and the third one. And these were all distributed to the far side. That means clear sky for the hospitals in our team. That will be more than 500 hospitals altogether. And I asked all of my colleagues from each hospital to tell the story of success story, or if they have any obstacles, how did they overcome, and we learn from each other. The first, the second, and the third book. Every 2 years, I have the book. See. This went to the World Tobacco Conference in Abu Dhabi. You can see 6 regions that we include our hospitals in this. And you can see that we have 46 tobacco cessation in all NCD. That means COPD, cardiovascular, stroke, DM, and psychiatric patients, because the psychiatrist is the one who takes care of the smoking cessation before I go on to bring it back to my NCD clinic. Because the patient will say, why do you send me to the psychiatrist? I'm not that mad. So I have to set up in my own clinic. And the second program would be on the 6 provinces that they thought that they were going to be the smoke-free provinces. They had 51 hospitals, but final results, we get only 29 hospitals from this, because these are not as good as the first group. And we get 34.5 cessation. The third project, again, we bring the hospitals that is better and better. And we have 14 hospitals. We hope these 14 hospitals will be the management center. I mean the knowledge management center. And funny, I'm not doing it in my hospital in Paulo. I send it out to my younger staff, and then they won the Diamond Nakara Award. I didn't do it, so don't worry. But Paulo won the first prize. And then the second, the last round was diamond for the whole country. On the anybody can come. It's not the special province. So this is the Minister of Health. He went and joined us. Now, formerly, Bangkok Metropolitan Health Center didn't do anything about smoking, and they have 58 centers. So we asked all of them, by the power of Professor Somsi and Professor Wanchat, help us to bring them together. And you see, I always go out with them, go to the place. And now, the last one, that means nowadays, we are teaching 13 KM centers, 12 in all 76 provinces in 6 regions, plus 1 in Bangkok. So you can see, we can spread area 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12 for 76. You can see that we spread in all regions. We did not keep it in any area for special. Now, after that, the clinical practice guideline, we have to ask all of the 26 organizations to join us, especially the Thai Diabetes Education Association. They join with us, Diabetes Association of Thailand, and the Royal College of Internal Medicine, who takes care of the cardiovascular, COPD, neurology, psychiatry, and at last we have the dentists join us as well. These are the outcomes of 10 years back. The first one we did in the all NCD, we did not divide in DM. So we had 1,479 patients. We got a very good tobacco cessation, 46. Remember I told you that we select all of the patients at the first, so we hope for the best. And then after that, in the 6th province, we get less because they're not that well prepared as the first one. We get 26 only, but 34 in all NCD, 26 for DM. And the last one in 14 hospital, we get 34, a little more than before, and 31 in DM. See, it's getting better. And the last one is even better for all fast. 532 hospital. We get 37 for all NCD and 33 for DM. I think it's getting better and better. I'm glad to see that. And I hope all of the Thai team will be very happy also. I have never showed this anywhere. Back to my own hospital. Dr. Sandy, before 2017, we were involved in the national health system. So we had a lot of smoking. So we had a better cessation rate because they are young and they are not that rich, so they listen to us. But after that, the cessation rate is a little bit down, 36, 50, and 33 and 36. However, why do I have that little? Because our smoker in Paulo is getting down and down and down. I hope it will be very near to zero. Almost the last slide. Key success factor from Dr. Chananan, who is the director of tobacco control in Thailand. We provide tobacco cessation for diabetics who are smoking. We protect the second-hand smoker that our diabetic patients who do not smoke don't get the nicotine. And lastly, we prevent. We have 3 P: prevent the new smoker, so they don't get the DM. We have some challenge. We need the policy from the government, and we need it to get through by the law. We need the administrators of all hospitals, and the very big problem to me is that the physician commitment, they have to diagnose and start the session. So we also want to be smoke-free Thailand and smoke-free world, as every one of you want. And that's finished my slides. I think I tell you the true story. There should be no question. I move on to Professor Prakash. Please, sir, please give me all of the best that you have done. Professor, now it's your turn.
Thank you very much, Dr. Ara. Thank
Welcome.
you for the cheerful, very energetic introduction, as well as please accept my congratulations for the WHO award to you.
Thank you.
Tobacco control. So good to hear that. Yeah, if my slides come on the screen, are they coming?
Slides. Dr. Prakash, slide. In the meantime, we'll collect the question and answer. If we cannot do it in this session, we'll keep it for you. I hope you
Sure.
you can help us.
Definitely, we will. I will definitely answer
Thank you,
all
sir.
the question. So even without slides, I think I can just start.
Yep.
In order to save the time. See, the topic that is given to me is the non-standard or alternate tobacco products and their effects on NCDs. Now, when we think of alternate tobacco products, especially these days, the biggest category of the product that comes to mind is the these electronic nicotine delivery devices and heat not burn and all those kind of products. But those products, I can see that in the conference they are being dealt by global experts very well. So I'm not going to touch on those products at all. There is one more category of alternate tobacco products, and those are smokeless tobacco products. So I will focus on smokeless tobacco products. That is my area of expertise also, and that is a huge problem in the country where I live, India, and also in many other countries. So I will demonstrate the global nature. I hope to demonstrate the global nature of this problem, which is not as well understood and appreciated as it ought to be, and the health effects. Now, unlike smoking, the amount of research that is available on smokeless tobacco is not as much. It's much less. So really, we don't have that much data to show the effects on individual NCD, although we do have risk data, but not in terms of numbers. But we have enough data to calculate and demonstrate all-cause mortality. So I will show that, and most of the all-cause mortality is obviously due to non-communicable diseases. So it does serve the point to show the importance of these alternate tobacco products for non-communicable diseases. So can I share my screen?
Please.
Yeah, okay. So in
Yes.
okay. Okay, can you, my slides are changing on the screen? Yeah. Okay. So yeah. So the most common tobacco products in the world, everybody knows, is cigarette. It is also the most researched product. Now we all understand, and from earlier presentation also, that cigarette is so harmful that not only any other consumer product, but any other tobacco product would pale in the comparison. So in fact, there is absolutely no point in the statement that this product is less harmful than cigarette, because cigarette is so harmful. Nothing else can be more harmful, should be more harmful than cigarette. But there are alternate tobacco products that are harmful in their own way. And the industry is, of course, constantly coming out with a large spectrum of alternate tobacco products. The main claim, of course, for promoting alternate tobacco products is that they are less harmful than cigarette. Unfortunately, what has happened is that some public health experts also agree with this kind of statement, explaining it as a harm reduction approach. But we have to remember that alternate tobacco products either are found to be harmful to health, even with the human studies, epidemiological studies, or if they are newly introduced, they are shown to be potentially harmful to health through laboratory-based research. So in the large spectrum of alternate tobacco products, one category is of smokeless tobacco products. As I said, the other categories which are very highly discussed these days is ends and HTPs, but I'm not considering those. They are being considered, I can see from the program, very well in the conference. Now, about smokeless tobacco products, the key fact is that unlike smoking product, they are not combusted at the time of use. I mean, that's a reason for calling them smokeless tobacco products. So if they are not, tobacco is not combusted, the products do not produce the same carcinogens and toxins as they are produced through combustion. So because of these reasons, they get touted as harm reduction products. In this presentation, I will deal with these products as their effect on NCDs and all-cause mortality. So in India and many other countries, the problem of smokeless tobacco has been recognized and researched for a long time. The worldview, therefore, was that even if smokeless tobacco is a problem, it's a minor one confined to just a few countries and few regions. Now, this was a misunderstanding. We increasingly got understood more and more. So the Center for Disease Control in the USA and National Cancer Institute of the USA and few independent experts, we got together to get a global perspective on the issue, because nothing was really, a global perspective was not available. So with contributions from experts from all across the world, this collaboration resulted in a 550-page comprehensive publication, and that publication is, I'm glad to say, is available online. It's called Smokeless Tobacco and Public Health, a Global Perspective. So global information I have taken from this volume, which is completely based on the research findings. As it is an NCI CDC publication, one can believe that. Now, these are the variety of smokeless tobacco products globally. They are all from different countries, USA, South America, many countries in Asia and India. So you can see the huge variety of tobacco products that are smokeless tobacco products that are there compared to smoking products, which are also, there is a variation, but comparatively much less. Only cigarette, bidis, and hookah, and pipe, and cheroot, and cigar. Now, there are many modes. Since there are such a huge variety of products, there are different ways of using these products. One is chewing, because when a product contains thick tobacco leaf or other leaves or a hard substance like nut, areca nut, or other condiments, the smokeless tobacco products is kept in the mouth and chewed. But if it is a moist powdered tobacco, which is often there with alkaline agent like canny and snus and lozenges, they can be put in the mouth and sucked. Also, if it is a powdered or pasted tobacco products, they are mishri or bajjar or gudaku or creamy snuff, they are simply applied in the mouth, teeth and gums. And it is interesting that in this part of the world, there is a huge misconception that tobacco products are good for dental health. So that is how there is a large amount of, the large prevalence and use of these kind of powdered and pasted tobacco products that get applied on teeth and gums, specifically for oral hygiene, which of course has a different kind of effect. Interestingly, there is one product that is used for gargling, and that is tobacco water, or called tuibur, and northeastern part of India, where tobacco smoke is passed through water, and that water is sold and used as tobacco water for gargling, and that also has its own nicotinic, at least nicotine ingestion effect. We got it tested in laboratory. Then inhalation. There are extremely fine dry powder like nasal snuff that are used for inhaling. And interestingly, a couple of centuries back, this was a very popular mode of using the smokeless tobacco, even in the Europe or royalties in the Britain and India. But now it has kind of almost died out, except perhaps in some tribes in South Africa, it is still quite common. Now, key findings when we look at the global perspective, they are that smokeless tobacco use is a global problem. Why? It affects 352 million persons across approximately 121 countries of all income. Majority of adult users, however, live in low and middle income countries in Southeast Asia. In some countries, smokeless tobacco use exceeds even cigarette use. So smokeless tobacco is a special problem among vulnerable populations, such as youth, women, and indigenous population. And we have a lot of data to really show that. Just to look at it in the map form, see that there are pockets like India, North America, some Scandinavian countries where smokeless tobacco is quite a problem. And then there are many other places where it's less of a problem. And of course, there are places where currently no information is available. But it's interesting to tell you my experience that up to 80s, 90s, we thought of 80s and 1980s and 1990s, we thought that it's not really a problem, big problem anywhere. But when you start looking and finding, it turns out that it is a problem at many places, many more places than we originally thought. So whenever surveys were done, we now highly recommend that include the use of smokeless tobacco as one particular parameter. Now, as you see from this pie chart, this is by the WHO regions. And the biggest 89% of the smokeless tobacco use is in Southeast Asia region, the region in which India and Thailand, both belong. And about 269 million persons are using, but it is present in all other WHO regions also, be it Americas or Africa or Western Pacific or Europe or Eastern Mediterranean. To a less extent, but it is there in every region of the WHO. So looking again at the global findings, 2/3 of the users are male and 1/3 are female. Nearly 1 in 10 adult and 1 in 20 adult females use SLT. More than 90% of the global smokeless tobacco users resides in low-income countries and low-middle-income countries. Smokeless tobacco use is 1 to 8 times higher in rural areas as compared to urban in Southeast Asia region and African region. And it's 1.5 to 17 times higher among poor as compared to rich in, again, Southeast Asia region and African region. The burden in Southeast Asia, as you can see from the slide, it is there in every country. Thailand, it is comparatively much lower, less than 4%, but otherwise it is quite considerable in all countries. Maldives, there is no data here, but there are data that it is there in Maldives also. And adolescent use also, interestingly, it is there. These are 13 to 15-year-old. And this data is from Global Youth Tobacco Survey. And even among them, there is substantive smokeless tobacco use. Health effects, most important, of course, we always think of the first is cancer. More than 30 carcinogens have been identified in the smokeless tobacco. Little less than smoking tobacco, but still they are quite a large number. Now, confirmatory evidence exists for oral cancer, esophageal, and pancreatic cancer, and that evidence has been evaluated by the International Agency for Research on Cancer using its own evaluation criteria, as it does for all other cancer-causing substances. Now, one interesting part of the use of smokeless tobacco is oral potentially malignant lesions, OPMD. They are quite common in the users of smokeless tobacco. The most important and common is leukoplakia, which has a malignant conversion rate and high prevalence rate. Erythroplakia is the most dangerous lesion for malignant transformation with a slightly lower, somewhat lower prevalence. Oral submucous fibrosis also is a pre-malignant condition with a high malignant transformation rate, and this is also associated with areca nut use, because when areca nut is used along with tobacco, it causes oral submucous fibrosis, and we have a great deal of now evidence on that. And it is by itself also, it is a debilitating disease without any cure. No known cure is there, no accepted line of treatment or cure exists even now for oral submucous fibrosis. Now, cardiovascular health effects, the mechanism is similar to cigarettes. And heart diseases could be related to nicotine, polycyclic aromatic hydrocarbon, heavy metals, hypertension, several SLT constituents such as nicotine, sodium, and licorice aggravate BP, especially diastolic BP, and stroke. SLT consumption is linked with increased risk of fatal ischemic heart diseases and stroke, and there are the relative risk range from 1.1 to 1.3 in different places. Other condition, diabetes and insulin resistance, particularly seen with heavy use of snus. We have also seen that in India, some data on that. Chronic rhinitis, common with inhaled SLT products such as dry snuff and Brazilian rape. Reproductive outcome due to polycyclic aromatic hydrocarbon and heavy metals, and psychological dependence, severe if it started at early age. And now the data shows that dependency for smokeless tobacco products is as strong as dependency on nicotine from smoking products. Now, a significant association is there for mortality due to all cause. The overall relative risk 1.22, all cancers 1.31, upper aerodigestive tract cancer 2.17, stomach cancer 1.33, cervical cancer, ischemic heart disease, and stroke. Now, there are significant differences among different WHO regions also. This is a forest plot meta-analysis for each of the WHO region from which data are available on smokeless tobacco use. And you see that for Southeast Asia region, the overall relative risk is 1.25, significant. For America region, it's 1.17, again significant, and for European region, 1.22, and again significant. So it is smokeless tobacco use, wherever it is used, is causing an increase in all-cause mortality. Now, we try to estimate the number of deaths. Globally, the number of deaths that could be attributed to smokeless tobacco use due to all causes was 652,494 with a little wide confidence limit. The Southeast Asia region bore the major proportion of this burden, and highest burden was due to stroke mortality, followed by all cancer mortality. The proportion of deaths was higher among women for all cause, all cancer, and ischemic heart disease in majority of regions. So there are differences also compared to mortality from smoking. And all this is from papers published in peer-reviewed journal. So now look at again, looking at the all-cause mortality attributable to smokeless tobacco use in different regions. And roughly it follows, of course, a similar pattern as to the prevalence of smokeless tobacco seen earlier. We have the disability adjusted life years have also been computed, and they were estimated to be about 46 million due to all causes, and major share, 80% of it was in Southeast Asia region. The burden due to cause-specific outcome was for all cancer and stroke, and proportion of daily was higher among women for all cause, all cancer, and IST. Now, Indian situation, I want to examine it in a little bit more detail, describe it, because it's a very special problem, a very large problem in India. Because India is the largest producer and consumer of smokeless tobacco products. Considerable amount of research is available from India on smokeless tobacco. So a few years back, scientists from India got together with Centers for Disease Control and National Cancer Institute, USA, to explore overall perspective of smokeless tobacco use in India. A lot of research papers that important to look at the overall perspective. So with contributions from a large number of experts, this collaboration resulted in a 450-page volume. This volume was published by the Ministry of Health and Family Welfare of the Government of India. This is the reference, and most important, it is available online. So you can get the entire this volume online. Now, it shows, the research shows that the variety of smokeless tobacco products in India is very, very high. Many different kinds of product, many different kind of packaging, many different kinds of brand names. And they are manufactured or made in a different ways. There are user-prepared or assembled tobacco products because tobacco leaves are not used by themselves generally. They are mixed with alkalining agent like slacked lime, and they can also be, areca nut can be, pieces can be added, other things can also be added. So, there is another product, mishri, where tobacco flakes are pyrolyzed on a hot plate till they get black. So these are user-prepared or assembled product. And the most traditional, the ancient one is a betel quid. So even now in a traditional Indian household, they may not use it, but still there would be a paraphernalia of preparing betel quid in the house. Custom made. Now, in India, you can be sure that if you are in an inhabited place, you are never far from a vendor of betel quid, a tobacco vendor or a betel quid vendor. So, and you go to them and they can prepare a betel quid as per your specification. They can also prepare other mixtures of tobacco products as per your specifications with slacked lime, with areca nut, with specific spices, flavors and condiments. Now there are many products that are manufactured on small scale, local scale and small scales, because these products are popular and used only in specific localities. So these include oral snuff, mishri, gul, that is oral moist snuff, and gudaku, which is a tobacco paste with molasses. And then there are manufactured, again there are many more products, khani, and kiwam and jardapatti, and some of there are products which are tobacco products marketed to betel quid vendors for putting them in the betel quid. This Chaini Khani is a very interesting product. If you look at the website of Chaini Khani, it gets advertised as snus. Now snus is a Swedish name for snuff, and Swedish tobacco company manufactures and markets snus all around the world. And because they say and they show that their manufacturing process results in a low nitrosamine levels in snus, this smokeless tobacco gets touted as a harm reduction product because snus has low carcinogenic potential. But we got this Chaini Khani, which calls itself snus, analyzed in the laboratory, and we published that, and it has a very high nitrosamine content. So better not go by name. All tobacco products are harmful. They contain high nicotine and tobacco-specific carcinogens. Now there are then products that are manufactured on large industrial scale, and most common is a gutka and pan masala. So they are basically mixture of tobacco, lime, slacked lime, calcium hydroxide, areca nut with sweetening and flavoring agents that are again specific to each manufacturer. And they are marketed with very attractive brand name, very attractive packaging, and using all kinds of traditional names and traditional values. This is an interesting product. As you see, it looks like a toothpaste. It is like a toothpaste. It was getting marketed as a toothpaste, but then there was a court case, and the court directed that one cannot put a tobacco in a toothpaste dentifrice. So they removed the word toothpaste. They call it creamy now, but market it exactly in the same kind of packaging, and it's available in tobacco shops. And there are people, of course, who use it. It has a very, very high nicotine content, very high nicotine and nicotinamide content. Mortality estimates for India, again, there are few studies. So meta-analysis was done, adjusted for smoking age and education, and observed RR for females were 1.34 and 1.17. The number of deaths attributable to SLT use in India is estimated to be 368,127, 217,000 women and 151,000 men, with 3/5 of deaths occurring among women. So you see, it is not a small problem in India. It's a very big problem in terms of health and in terms of mortality. So these estimates call for targeted public health intervention in India, focusing on smokeless tobacco products, especially among women, and especially among women because also of the reproductive health effects of smokeless tobacco use during pregnancy. And I will show you those next. The estimates due to SLT tobacco use in India on reproductive outcomes. So again, there are meta-analysis for low birth weight, preterm birth, and stillbirth. The pooled odds ratio was significant for all three outcomes: low birth weight 1.88, preterm birth 1.39, and stillbirth 2.85. So you can see the forest plot of the meta-analysis, and you can see that this is first is LBW with 1.91 overall relative risk, and preterm birth 1.39, and stillbirth 2.85. This is from of course, a research paper that's referred here. So to conclude, the majority of studies provide sufficient evidence to delineate the role of smokeless tobacco in tobacco attributable mortality. It can certainly be not called a safe habit or even less harmful habit, because it is very, very harmful. It is widely recognized that the tobacco control activities have often ignored SLT component. Now, again, there are many research papers on examining policies in different countries on smokeless tobacco, and quite often the policy part sort of doesn't take care of smokeless tobacco as much as it does for smoking. So with these kind of robust estimates, policymakers could be convinced to divert some of their attention to this growing problem. With a major burden in the Southeast Asia region and high mortality rate in females, fight against smokeless tobacco becomes even more important. So these, but there are challenges. So just very small, brief recap of the challenges. Smokeless tobacco is not considered a priority in tobacco control arena. Even globally, that was true at least up to 1980. Hardly anybody talked about smokeless tobacco outside India. Limited data to help develop policies and program, pricing, sale of SLT product, impact on household economics, health effects, and costs. So, these are the topics on which there is plenty of research and information that is available on smoking, but not so much on smokeless tobacco. Another challenge is the diversity of product. As you said, it is not just one or two or three products, it's a huge spectrum of products. There is also emergence of novel products in the market, lack of knowledge in everywhere about the harms of smokeless tobacco, and another challenge is some public health advocates who advocate ST for harm reduction. Thank you all for your attention, and I think I'm reasonably well within my time. Thank you all very much. Thank you, Dr. Arya.
they are unheard of. I have never heard of any energetic cardiology and unheard of the products in the market. So I think I have one question for both speakers. Dr. Prakash,
Yes, please.
what do you think is you're going to do in your country with this big problem about these kind of products? Whom do you go to
Uh,
see? Who can help you?
yeah, we are basically going to the Ministry of Health and Family Welfare. And one category of product that is we call gutka, a very, very harmful product, causing lot of problem among children also. And state by state, we have been successful through public health advocacy in getting that product banned. So banned quite doesn't mean that we already know that it is not available and not at all used, but it has made a huge difference. So the product is now banned in almost all states in India. There are other smokeless tobacco products also that are getting banned. And the regulation of smokeless tobacco product is almost exactly as per the smoking products. We don't differentiate between smoking product and smokeless tobacco product. And although we don't have the evidence of second-hand smoke for use of smokeless tobacco products in public places, with current COVID epidemic especially, there is a campaign and regulations against spitting. And use of smokeless tobacco causes spitting everywhere. I mean, India is very bad, notorious for having spits all over, and that is because of smokeless tobacco. But now there is a great attention of the government and authorities and public also on the harm of spitting due to COVID. And the spitting is due to smokeless tobacco. So if the spitting is curbed, the smokeless tobacco use in public will also get curbed to a great extent. So there are lots of, there are many other different, there are pictorial warning labels on smokeless tobacco products, just like smoking products. So there are many attempts, there are many challenges also, but I think we are going forward, although not as fast as we would like to, but I think we are still going forward.
Okay, back to Sandy. I didn't forget you, my younger brother. Please give me an idea how to talk to the cardiologists and the other specialists in internal medicine to do as you do.
Yeah, I think this is a very important point because smoking cessation or helping patients quit, everyone thinks it's someone else's job. Yeah, that here we are cardiologists, we're putting in defibrillators, we're stenting, we're doing rehab, we're doing heart failure management, and now you want us to be experts in smoking cessation. I think we have to be realistic. We can't do everything. And the way we did it in one of our hospitals is to make friends. And we've got health professionals. If I would give you the name of a lady called Lynn. Lynn is employed for smoking cessation. And she used to sit next door in my clinic. And I would see a patient who's come back after having successful bypass and stent, is still smoking. And I will say, I think it's very important now that you've been given a new set of arteries, we protect you, and I need you to meet Lynn next door, who will go through all the options and then contact you. So I think we've got to be a multidisciplinary team and then train up people who know about counseling, who know about the pharmacotherapy, and tailor the therapies of the patient. So I think the other thing, Arya, is to increase the awareness. Like you say, you want to, give talks to the other clinicians. People need to know what role they should play because whatever speciality you are in medicine, everyone is a preventative doctor.
So I think as the moderator and the MC, I wish to thank both of you my professor and my younger brother very much. I wish to go to London and see you in your place. I wish to go to Mumbai to see Dr. Prakash. And I wish both of you to come to Bangkok
Bangkok.
some of
Sure.
these days.
Love coming to Bangkok. I'll come.
Yeah, please come, and I'll
Lovely
go.
place.
And I'll go. We exchange. So I hope every audience is appreciate your talk very much. But we will have to go to the opening ceremony. I thank you very, very much. I hope to see you soon. Hope for the best for everything, for yourself and your family and your country. I said goodbye to you, my brother and my professor.
Thank
Okay,
you. Thank
bye-bye.
you very much, Dr. Araya.
Yeah.
Thank you. Bye-bye.
10 out of 10 for chairing. Fantastic job.
Oh, thank you very much. I enjoy it. That's my job.
Yes, obviously. Obviously, that's how you do such a good job.
Thank you very much. Okay, bye-bye. I see you.
Bye-bye. Bye-bye.
Okay, I'd like to close this session. Thank you, staff.
Okay, bye. We leave now. Yeah.